Gary, you and I grew up together, and then we both went off to medical school in different places, had a completely different experience, and then we ended up in the same practice. I'm a neurosurgeon, you're an orthopedic surgeon, and when you get up and present, I'm blown away at what you know that I don't know. It's crazy to me that I could study medicine and neurosurgery for years and years and years and have almost no idea the things that you know. And I think it's been really cool to be in practice together and to learn from each other and then to offer to patients that collective experience in neurosurgery and in orthopedic surgery. What do you think about being in a practice with neuro and ortho?
Well, I think it enhances the patient's treatment outcomes. So there definitely are things that also you present on that I'm like, well, I didn't even know that. And we're talking about spine, and I did spine rotations in residency. And so I think adding that expertise, together definitely yields itself to give a better patient outcome. So yeah, it has been fun, to join Summit and to get to work on patients together.
One of the challenges that I do have, though, is when I come to the operating room, I think they're disappointed that it's not the other Dr. Edwards, because Gary's so funny and entertaining, so that everybody really enjoys being in the operating room with you, and I do too when I'm able to stop by. So you talked today about some shoulder pain issues with patients, and other than a pinched nerve in the neck, what are some common causes of shoulder pain?
So I think rotator cuff is a super common cause. Arthritis of both the actual shoulder joint, so the glenohumeral joint, as well as the AC joint. There's a lot of biceps tendinopathy and labral tears would be kind of the rundown of some of the most common causes. Sometimes we get a disease called frozen shoulder, where for whatever reason the body is triggered to kind of shrink the capsule down, and that can be extremely painful.
Specifically with rotator cuff, which we discussed this morning, what are the common symptoms of a rotator cuff injury?
Yeah, so the book answer is pain over the lateral aspect of the shoulder, often pain at night, pain with overhead activity, pain that wakes them up actually sleeping are the common causes, and the feeling of like burning or weakness when you lift your arm.
And then as far as non-surgical management of a rotator cuff injury, what do you typically recommend for patients?
So no overhead activity, a full course of physical therapy, sometimes some sling immobilization and anti-inflammatory medications and icing, kind of relative rest for a short period, and then starting to get the patient active again is kind of our mainstay of treatment.
You also mentioned a diagnostic workup and emphasized the importance of x-rays. Could you talk about that just for a minute?
Yeah, so basics of orthopedics is to get an x-ray. A lot of us, I think for good reason, want to jump to an MRI. The MRI shows a good evaluation of the ligaments, can show some things like stress fracture or a tumor, or some things, a tendon tear that an x-ray doesn't really show. But there are a lot of things that you can glean from x-rays. I think fractures are better visualized on x-ray. I think some of the arthritis of the glenohumeral joint as well as the AC joint are better visualized on x-ray. There's some of our standard measurements that we make on x-ray that can give us a little bit better sense. When you take a shoulder x-ray, you're sitting up, and so it's a dynamic view, and so it's a real life position of where your shoulder is in space and how it's working together. When you take an MRI, you're lying in a tube, and so it's a little bit artificial where the position of that shoulder is because it's being supported by the back of the MRI machine. So those are a few of the reasons why x-ray is kind of our standard. I'd be lying if I didn't say sometimes it's because insurance requires it, but yeah, those are.
I found the same thing in the spine, that the combination of dynamic and positional x-rays with the MRI give you most of your radiographic information. Sometimes the CT is helpful. So let's say, for example, that you're planning to take a patient to surgery for a rotator cuff injury. What are the risk factors that surgery ends up resulting in another rotator cuff tear?
Yeah, so I think the patient's general health status, the age of the patient, specifically diabetes has been linked with rotator cuff failure, smoking status, The amount of time that the rotator cuff has been torn is effective. One of the things we went over today was a specific score laying out age, tear size, both in the AP diameter, so how far across the rotator cuff the tear extends, and also retraction, so how far back the rotator cuff is retracted, are both important elements. The other element that this paper brought out was bone mineral density. So if someone has osteoporosis or a score less than 2.5, then that's linked with failure of our primary repair.
You said in the rounds this morning that rotator cuff problems are biology problems. What do you mean by that?
So other than an acute setting where someone's had a traumatic injury, right, a chronic rotator cuff tear ultimately means that the tendon is getting worn out faster than the body's able to remodel it. It's degenerative disease. And so on some level, as I've thought about rotator cuff throughout my training, sometimes it doesn't make a ton of sense all the time to take a diseased tendon that has torn without a significant traumatic injury. In fact, most patients don't remember how they quote unquote hurt it, and take that diseased tendon and attach it to a diseased bone and then hope it heals. And then if it does heal, how have we made that stronger or better? There's suture, tapes, or whatever that we add. So one of the focuses of today's talk was adding a biologic augmentation. I think that there's kind of 5 general forms of biologic augmentation. The first 2 being kind of cells, either platelet-rich plasma, where we take blood and spin it down, or we take actual bone marrow aspirate and spin that down to try to get stem cells or healing cells into the shoulder. The other options would be an allograft, so a tendon or a piece of tissue from a cadaver, a xenograft, so a piece of tissue or a tendon from an animal, and then the other is autograft, so the patient's own tendon. So those are kind of the biologic options that we have. The data is still a little bit new on those, and we're trying to tease out what combination of graft plus or minus cells do we need to do to add to a patient that has a high risk of failure.
That's cool. A lot of big terms, even for me to fully comprehend, but thanks for describing it. And it was great discussion. And some things to think about, some exciting new innovation coming in orthopedics in terms of improving outcomes for patients especially that would otherwise have had a very high risk of surgery failing and now could perhaps heal up well and have restored function.
Yeah, some of the studies are really promising. Some of the studies, the re-tear rate is much less. Some of the studies are also not as promising. And so I always like to not be the first adopter, but I want to be in the first group once it's established to adopt. And so there's kind of that, as a physician, that you want the best for your patients. It makes me a little nervous to read a study hot off the press and immediately implement it. You kind of want to see data. 1-year data doesn't really help you too much. 2 years also doesn't really help you much, but when you start to get 5 and 10-year data that starts to be very promising for this type of thing, that's when you want to start, maybe think about changing your practice or evolving it to add some of these elements.
I agree, and I think the sweet spot is the data is encouraging and it makes sense from a biology standpoint.
Yeah.
And when you get those 2 things together, it's like, okay, I'm ready to make that next innovation.
Yeah.
That's what I found too.
And sometimes we're tempted to go just based on our own experience. Well, I tried that once and it didn't work. And I think if we step back and look at that objectively, we have levels of evidence in medicine that's like level 5 evidence. That's like expert opinion. So I think paying attention to the studies and looking at meta-analysis and looking at hundreds of thousands of patients as opposed to a couple, I think is important as well.
Well, you better get off to surgery, right? You've got a big day.
Yeah, a couple cases.
Thanks for staying after.
Yeah, no
Appreciate
problem.
it.